Hi everyone, and welcome to Families USA's first Community Health Worker Sustainability Collaborative webinar using Medicaid Managed Care contracts to support community health workers. My name is Raven Gomez, and I am a campaigns assistant here at Families USA, and I'll be kicking us off for today's webinar. So we will be recording the presentation portion of today's webinar, but we will have a question and answer discussion at the end that will not be recorded. Q&A will be off the record because we want this to be a really engaging conversation where everyone feels comfortable talking about their work. Currently, everyone is muted, but if you have a question during the presentation today, for today's portion of the webinar, you can type your question into the chat box. And if you have a question during the Q&A portion of today's webinar, you can unmute your line by pressing *7. And in order to minimize on background noise, we do ask that you remute your lines after you finish speaking by pressing *6. Once the webinar concludes, a brief survey will pop up onto your screen, and we would love for you all to take a minute to fill it out. There's just a few quick questions, and your feedback is extremely valuable to us so we can ensure that we're providing you with the tools and resources that you need for your work. Finally, if you are currently not a part of our Community Health Workers Sustainability Collaborative and would like to be, just shoot us a quick email to chwcollaborative@familiesusa.org, and we can make sure to add you to the listserv. So your other speaker for today's webinar is Ellen Albertin. Ellen is a senior policy analyst here at Families USA and will be talking about specific contract language. Charlie Alfaro was planning to be with us today but was unfortunately unable to make it, but we will definitely do our best to present on his New Mexico model, which you can find out more from on our collaborative hub on the Families USA website. And now that I've introduced our speakers, before we get started, for those of you who are not familiar with Families USA, I want to give you all a brief overview of who we are and what we do. So we are a national, nonpartisan, nonprofit healthcare policy advocacy organization, and our vision is to have a nation where the best health and healthcare are equally accessible to all. The work we do surrounding community health workers plays a big part into this mission because community health workers have a proven track record of improving health outcomes, increasing the value of healthcare, and reducing health disparities. So we know many of you are already familiar with who community health workers are and what they do, but I do want to take a quick minute to quickly level set for those of you who are on the call that aren't as familiar with community health workers. So community health workers are trusted members of their community who bridge the gap between the healthcare system, social services, and their community. As you can see from this slide, community health workers can go by many different titles, and today we'll be using community health workers as an umbrella term, but we do recognize that there are important distinctions in how people doing this work envision their roles. Regardless of their title, though, we know a common challenge is finding sustainable funding for this really important work, and that's what our Community Health Worker Collaborative is all about, finding pathways for sustainable funding. And one of those pathways for sustainable funding is Medicaid managed care. So Medicaid managed care is when a state Medicaid office contracts with a health plan to provide health benefits and other services to people who have Medicaid. Typically, a Medicaid managed care organization is paid a per member per month payment of people who are enrolled in the managed care plan, and managed care is really dominant in Medicaid. In fact, many states are looking to expand the use of Medicaid managed care, and over 2/3 of enrollees already receive benefits. For example, in Mississippi, they actually use two different Medicaid managed care organizations, Magnolia Health and United Healthcare, whose logos you can see up on this slide. And people on Medicaid in this state would mostly interact with these two companies when accessing and dealing with their benefits. So there's a lot of interest in using Medicaid managed care to fund community health workers, and there are a few reasons as to why that is. When using Medicaid managed care, there is typically more flexibility than there is with Medicaid to cover additional services. Contracts already have care coordination in place, and in these contracts, there's a lot of ways to incentivize the use of community health workers. Providers are also able to work with Medicaid managed care organizations to support community health workers. So now I'm going to pass it over to Ellen, who will be diving into some Medicaid managed care contract language. So Ellen, you can take it away.
Thanks, Raven, for providing such a great introduction to our webinar today. like Raven said, there are a lot of reasons why a lot of folks are really interested in managed care as an option to provide the sustainable funding for community health workers. And I'm going to cover some of the different ways of kind of approaching these contracts with managed care companies and how we can better use this contracting process and the language that is inserted into these contracts to support community health workers and some different elements we might want to consider. So when states are looking to either put their Medicaid program into managed care or just renew managed care contracts if they already have it in place, they will put out what's called a request for proposals, an RFP, some other type of document out there that says we're looking for plans to do this for us. And in those documents, it'll outline what would a health plan like United or Magnolia, like that Raven mentioned, have to do in order to successfully bid or successfully apply and kind of be in compliance with the contractual requirements that the state Medicaid program is putting in place. Now, much of the language we're going to kind of dive into today and talk about comes from those documents, the documents that the state puts out and then the managed care plans will later respond to. And I'll point out when we're talking about language from a different document. This is a little bit of background if you are interested in seeing what these documents look like in your state, because we won't do a 50-state survey today. Most of these documents are publicly accessible, but as Raven can certainly attest to, as she did a lot of the searching for us, they're not always the easiest to find. So if this is something you want to look more into in your state and you're having trouble finding these documents, please feel free to reach out to us, and we would love to partner with you to get that information. And as we review this language, I'll point out some considerations if you're thinking about advocating with your state Medicaid agency directly, things you can ask them to include in their request for proposals. But also, if you're a healthcare center or other type of services provider, there are also some things you can do if you're trying to approach a managed care plan on your own. As the managed care plan has to build its network of providers and the folks that its clients are going to receive services from, there's opportunity on that end of the contracting process as well. So that's kind of what Raven was getting at by saying that there are a lot of opportunities and a lot of places to put in requirements or incentives. And just an early plug, we'll actually be releasing an issue brief on a lot of what we're going to talk about here today. That's going to take an even deeper dive into this contract language and how it can be used to support community health workers. That'll be coming out in May, so you guys are all actually getting a sneak peek, and I hope you'll check that out when it's released as well. All right, so let's dive into this language. So first, let's look at a few different ways of including community health workers in these contracts. So as Raven mentioned, Medicaid managed care companies, I might refer to them as Medicaid MCOs or just MCOs throughout this webinar, they already have to meet certain care coordination requirements. And these are, particularly as there's more and more attention being given to what we call the social determinants of health, things like access to healthy foods or safe and affordable housing. And at the same time, there's a lot of pressure to be a more value-based healthcare system where we focus on and reward providers for improving quality and improving outcomes and less so for just delivering more services. There's increasing attention on how we can improve care coordination and what are the really effective strategies for doing this better. So that's why there's definitely increased attention on community health workers in this space. So while this language that's from Rhode Island doesn't explicitly require community health workers, it does require some roles and some functions that we know community health workers are really great at. So this might be a great starting point, looking at your state's contracts and see what does that language already say? Could it be strengthened? Could we insert, social determinants of health in there to make it clear that we want these plans to be doing care coordination that takes into account those issues? And then if you're a healthcare center or other provider, you might be able to approach the plans that you're already working with and say, we've got this really successful community health worker program. We would really appreciate some more sustainable funding for it because we know it's going to help you meet these care coordination requirements that you already have to do. And this way everybody wins. So you can also put in more specific or more explicit requirements for community health workers into these contracts. So this one is from Michigan. And here Michigan is calling for their MCOs to support CHW programs that are delivered by community-based organizations. And that Michigan's MCOs have to support the design and implementation of these CHW interventions. And I just want to note here really quickly that, as there's this increasing attention to the work of community health workers and the value that they can provide, Some health plans and other stakeholders in the healthcare space will often hire their own staff to be CHWs, and it's kind of this bandwagon effect. But there's some real concern about whether the MCOs or other people in the healthcare space always really understand what is so special and unique about community health workers, and how they're so rooted in their communities and how they're from those communities. So I think if we're inserting requirements into MCO contracts about using community health workers, it can be really important to put in something like we have here in Michigan about working with community-based organizations. And that could help ensure that the CHWs that the MCO is working with aren't just folks who are primarily sitting in an office or working over the phone, but they're getting out into the community and that they're really rooted in those communities. So just something to keep in mind if you're advocating for the inclusion of CHW requirements. Who will be hiring them, who do they work for, where do they work, and so on. So here's another example from New Mexico about requiring community health workers in the MCO contracts. While this one doesn't have the same community-based organization requirement that we saw on the last slide from Michigan, I think this is a great example of how in the New Mexico contract they were really explicit about community health workers encompassing all these other titles that folks doing this great work may be working under. So another thing to consider, what are the titles that people in your state or your region go by that are important to make sure that they're included so they don't end up being inadvertently excluded from these contracts. Great, some more language from New Mexico, and I included this language to point out that this really ties together both the general approach to including CHWs and the specific approach to including CHWs by bringing together the care coordination requirements and CHW requirements. So in New Mexico Medicaid managed care, the MCOs have to maintain a certain ratio of care coordinators to Medicaid beneficiaries. And we saw on the previous slide how MCOs are also required to have a network of community health workers. So this is just bringing those things together and saying to the Medicaid MCO plans in New Mexico that when you're figuring out your ratio, if you're meeting that ratio of care coordinators to Medicaid enrollees, community health workers can count as care coordinators. So it might be a little bit easier for them to meet that required ratio. All right, so once community health workers are included in a Medicaid managed care contract, it's also really important to think about how community health workers are being defined in that contract, and however we can, making sure that those definitions really align with the definitions that community health worker associations or alliances are defining for themselves, and making sure that these definitions stay really rooted in the community and defined by community health workers themselves and not just by the managed care plan. So in some states there may already actually be a statutory definition of community health worker, so that might end up as the definition in your managed care contract. That's the case here in Minnesota, where they actually enacted broader Medicaid coverage of community health workers several years ago. So they defined it in legislation of, community health workers are those people who have gone through the certification process they have in Minnesota, or the grandparenting into being certified in Minnesota, and that's how they are also defined in Medicaid managed care contracts. But you can also use the contract to define community health workers, and many contracts do this. So in Washington State, this definition tracks somewhat with other definitions, and you can see that this contract is really explicit about community health workers also including community health representatives, which is a term that's really specific to American Indian and Alaska Native communities. So if you are a part of a community health worker association who has created its own definition of CHWs, or if you're a part of a CHW program at a clinic or other health center, and you really adopt the American Public Health Association's definition, this will be something you want to make sure is represented in the contract, so that you still get to define yourselves, and that none of the folks that are doing this great work with you end up getting excluded by how CHW gets defined in the contract. And here's a definition from Nebraska that I just wanted to point out, because I think it's really notable in that, at least in theory, it seems to recognize the really community rootedness, really on the ground. I mean, they use the phrase feet on the street efforts. So it seems to, again, at least in theory, recognize that community health workers are folks who are rooted in the community, and they do have this specialized knowledge. So I kind of just offer that up as an example of things to think about if CHWs are not already defined in these contracts, or if you would like to improve or strengthen those definitions. And as I'm sure many of you are already aware, as I know many of you have worked on defining core competencies for community health workers, the actual definition is just one part or one step. It's also really important to define what are those core competencies of folks who are CHWs. What do they need to know? What do they need to be able to do? And sometimes these competencies will also get included in the contract, so it's another place to both look to strengthen it and also just make sure it's tracking with what you all as CHWs have defined for yourselves. So looking at Michigan, the MCO is responsible for ensuring that the community health workers it works with or contracts with meets these core competencies. And the exact list of core competencies and how they are arranged can, there's a lot of similarity between states and between programs that have listed competencies, but they sometimes differ in how they are grouped or defined, and there might be some additional ones depending on the state or the program that it's looking at. So these are the competencies from Michigan. And if you compare that to the Michigan Community Health Worker Alliance, which has also defined the core competencies for its folks, they track pretty closely. So all of the bulleted core competencies that are in the black text, those are in both the MCO contracts and in the Michigan Community Health Worker Alliance's core competencies, with the exception of the navigating community services. That one seems to track pretty closely to organization and resources, community and personal strategies, which is included in the Community Health Worker Alliance's list of core competencies. And the Community Health Worker Alliance's list also includes mental health, which I'm sure, as many of you know, is really important for thinking of health in a more holistic sense, but that is not currently included in the Michigan MCO's contract list of core competencies. So just something to maybe look at. If you have a list of core competencies, if your state or association has defined those, are those tracking well with what's in the Medicaid managed care contracts? But it doesn't end with core competencies either, as some contracts also go on to either define roles or services that CHWs can or must provide. So the text here in blue, this is a place where the language is not from that request for proposals that I said the state often puts out. This text is actually from one plan. I believe this was from a United Healthcare plan in Nebraska. This is what it said in response to that request for proposals that the state put out. So here, it's also a great example of how even though the question or the contract requirement from the state, which you see is for the MCO to detail the strategies it will use to influence member behavior, to access appropriate health care and adopt healthier lifestyles, the plan itself chose to respond to this requirement or this question by talking about its work with community health workers, and that this is how it meets that requirement. So here, a role of the CHWs is to connect to resources and help folks ensure that they're receiving timely and appropriate care, and where appropriate, engage in kind of behavior change and those issues. Contracts can also further define it by actually just listing out the services that either, again, they're required to have their CHWs available for, or just kind of establishes a floor. So this is not an exhaustive list of services that CHWs can then provide under the contract. So you can see that this tracks pretty well with a lot of things that CHWs do as far as conducting home visits, which we know can be so important, helping folks set up and arrange medical appointments and just navigate the healthcare system. But what I also like about this list of services is that it doesn't just include that access to care or things that are really within the kind of biomedical model of care and health. It also includes being your client's advocate with their providers, and we know that can be really important. And it includes helping boost client morale and self-esteem and self-worth. And here's just another list of services. This one is from the New Mexico contract. And this one, these are services that the Medicaid managed care organization must make available to their through community health workers. All right. So another element that you might want to think about in putting together CHW elements into a contract is ratios. So we mentioned before that there can be requirements in managed care plans to have a ratio of care coordinators to the number of people on Medicaid who are enrolled in this plan. Well, you can put a similar requirement in there for a ratio of community health workers to people enrolled in the plan. So here's one from Michigan where there has to be at least one full-time CHW per 20,000 enrollees. Now, of course, that does not mean every community health worker in Michigan has to have 20,000 clients, because that would be a lot. But it does kind of establish a floor of starting to make sure that we're building this network of community health workers to be available for enrollees. And this is also important. I think this language from Michigan is also important because it shows that the ratio alone is maybe not enough, because you also need to put in there possibly some geographic requirements if you know that there are a lot of CHWs in one area of the state, but you want to make sure that people in all areas of your state have access to a community health worker. That's another thing to consider. So the last bit of contract language that we're going to talk about today, I know we're putting a lot of text on the slides for you, so don't worry, we're going to make this one available to you all afterwards as well. But as you're thinking about what elements to put in your contract, it's also important to think about what happens after you get those included. How do you know they're working? How do you know the managed care plans are using community health workers effectively, that they're actually doing what they say they're doing? If you think back to that great Nebraska example of feet on the street, I said it's a really great definition in theory, but how do we make sure that's actually how they're implementing CHW programs? So here's just an example from Michigan. The contractor has to report on the effectiveness of its programs, including the in-person support services that community health workers provide. So thinking about how you might want to structure those reporting or evaluation requirements for any CHW elements you put in the contract. And then, of course, any public reporting requirements you can put in there are really helpful too. We mentioned before that it's kind of hard to access some of these documents, so the more we can put in there about that you have to publicly report this data, you have to make it on a user-friendly website, it has to be really easy for consumers to find. All of those things are great ideas to think about in thinking of the contract. All right, so now we're going to switch gears a little bit, and Charlie wasn't able to be with us today. Charlie O'Farrell, the Executive Director of the Southwest Center for Health Innovation, but this model is really built by him, and he's the expert on this model. So I'll do my best to represent this great work that he's doing in his state. So this is going to talk about the other side of the contracting process. So we talked about what the state can put in as requirements or incentives for Medicaid managed care plans to do when they contract with plans. This is going to talk about the other side. What can health centers or other providers of services do when they're directly dealing with the Medicaid managed care plans that their patients and their clients are enrolled in? So this model, the Integrated Primary and Community Support, or the IPACS model, it's really a really innovative contracting design. And it started as a pilot back in 2005 with just a few clinics, and at the beginning, just one Medicaid MCO, which was Molina, which was one of the MCOs in New Mexico at that time. And this community health worker program was just targeted at those enrollees who were the highest utilizers, those who were using the most healthcare services, who generated the most cost typically as well. And so in this pilot, Molina paid an additional per member per month. You might remember Raven mentioned at the beginning that MCOs are usually paid a per member per month per enrollee. So then here, the plan paid an additional one to the providers for each of these highest utilizers. And if you check out our CHW Sustainability Collaborative Resource Hub, we actually did a case study on this IPACS model that we released late last year, and we also have some links up there that will take you directly to an implementation toolkit that this model put together in case you want to implement it in your own clinic as well. So this chart just gives you a sense of what we're talking about when we say the highest utilizers. These are the folks in that smallest circle, level 3, intensive care coordination. So over on the right, it's a relatively small group of folks, but you can see that the dashed red line represents that they often generate a disproportionate share of the cost. And that's because folks who are in this group typically have multiple chronic conditions, often mental and behavioral health conditions, maybe substance use problems. So there's just a lot of need for services, and maybe they're not connected to a primary care provider, so they're using the emergency department or other services where there might be a lower cost and more appropriate, more helpful option for them. Okay. So in this model, those high utilizers were automatically referred to a community health worker. And this had a really unique care team design, at least at one of the clinics in the pilot. Instead of always, just waiting for another clinician or other person to recognize that maybe this person can benefit from a community health worker, the community health workers actually had, kind of their own department, the Family and Support Services Department, that was co-equal with, physical health and behavioral health and the other departments at the clinic. So it was really recognizing the value and the, how important community health workers could be to this work. So each CHW was responsible for about 25 to 30 patients who would stay in the program, 3 to 6 months. It wasn't really, strict, but it was just kind of when the client felt that they, had the resources and the support and the knowledge to, better access services and have their chronic conditions, better managed. And you can see on the right some of the services that they provided, and these will probably be familiar to you if you're a community health worker or you work with CHWs. So helping folks navigate the healthcare system and other services, doing those really important home visits to figure out if there are, environmental issues going on there, helping with barriers to care like transportation, and it worked. It really, really worked. It resulted in much fewer emergency department visits, fewer inpatient admissions, fewer prescriptions for folks in this program. And because of all of that, it generated a really high return on investment. So for every $4 Molina invested, or every dollar Molina invested into this program, it got $4 back, which is a pretty good return on investment. Okay. So because it was so successful, they wanted to expand this pilot into the level 2 circles and the level 1 circles. So they got smaller per member per month from these managed care companies to do that. And the level 2 folks are folks who still have some chronic health conditions, still need some assistance in managing those, but don't need quite as intensive of that support. And then the level 1 is doing more of that community health promotion, prevention, really population health level stuff. But since the return on investment doesn't show up as quickly with this because you're doing more of that prevention, these folks weren't using as much services in terms of like the emergency department and inpatient admissions. They didn't have quite the return on investment in that time period that often appeals to a managed care company. So they've had, some kind of some Medicaid managed care plans will participate in the program but haven't fully committed to it the same way that they committed to the one that really targeted the highest utilizers.